evening, everyone. I thank the organizers for giving me this opportunity. So, my topic today is treatment of triple positive disease and enigma with crosstalks. So, this is how we treat breast cancer. We have always said breast cancer has the ERPR and the HER2 subgroups, but we believe all of them are very heterogeneous and all the subgroups have a heterogeneous population. So we divide our ER positive into the ER positive, PR positive, HER2 negative, low KIs into luminal A. We do the ERPR positive and the HER2 positives into the luminal B. This is what is the segment where we are talking of triple positive disease, the ER positive, PR positive, HER2 positive, the luminal B disease. We have the ERPR negative and the HER2 positive, which we are calling the HER2 enriched disease. And we have the HER2 and the ERPR negative, the basal types, which mainly include the triple negative disease. So we've seen how adjuvant trastuzumab has made a change in breast cancer management over years. We've heard about this, a clear improvement in disease-free survival, clear improvement in overall survival. We talk of hazards of 0.6 to 0.7 by adding trastuzumab to the adjuvant setting. But all these trials take up all the HER2 positive patients together, both the ER negative and the ER positive patients. Recently, a few years back, we saw the HERA trials 11-year follow-up and amazing results. We have seen 10 years overall survival data crossing 80%. But what we learned from this HERA data was this, that when you look at the populations which are ER positive and ER negative, there is a slight difference. So first coming to the ER positive or the triple positive patients, these are patients who have a better long-term overall survival compared to the ER negative population. Now, these ER positive patients, what we see, they do not relapse much in the first 5 years. So in the first 5 years, they are doing better, but they continue to relapse after 5 years, and slowly the survival curves go down. But if you look at the ER negative population, these patients, they relapse much faster in the first 5 years, and then after 5 years, the relapse rates is very less. This is almost like behaving like a triple negative population where you have relapse in the first 5 years, and then you don't have much relapses. But the triple positive patients, they are relapsing not much in the first 5 years, but later slowly they keep relapsing, just like our luminal A subtype patients. So clearly we are seeing a different behavior in the triple positives versus the ER negatives. Now, what this trial also showed us that in the ER negative patients, when they relapse, you have much more of visceral metastasis. But when you have ER positive patients relapsing, you have much more of the bone metastasis. And lastly, what we clearly see is trastuzumab has a clear impact in overall survival, irrespective of whether it is a ER negative subgroup or whether it's a ER positive subgroup. We've seen this analysis, Madam just showed it to us, that how PCR is impacting our decision making. There's a lot of debate on PCR, but what we clearly know is patients who get PCR clearly have a better survival. Those patients who don't get PCR may have a little lesser survival. Now, again, it does not mean all patients fit into this whole subgroup with PCR, good and bad. We are seeing that patients who are triple positive, even though they always will have lesser PAT-CR. And we have seen this in the pre-trastuzumab era, where you just gave chemo, ER positive patients have a lesser PAT-CR, ER negative patients have a much higher PAT-CR. And again, when the trastuzumab era, ER negative patients have a much higher PAT-CR, but ER positive, less PAT-CR. And clearly we have seen this difference. But when we see the survival, we're seeing that patients in the ER negative subgroup, the PAT-CR has a much higher implication in OS. But in PAT-CR, in the ER positive patients or the triple positive patients, the impact is much lesser. They may not get a PAT-CR, but they may continue to have a very good survival in the long term. And this is where there is a difference in the prognosis and survival of this subgroup. Well, we have moved to neoadjuvant therapy. Ma'am just discussed this about the two pivotal neoadjuvant trials. And again, from here, what we see, the Neosphere data, that was the pivotal data of pertuzumab, trastuzumab with chemotherapy. Again, clearly what it showed us, when we added pertuzumab, we increased the pathological CR much higher than just trastuzumab. But it also showed us, when you divide them into the hormone positive and the hormones negative subgroup, you clearly are having a doubling of PAT-CR in the hormone negative subgroup. And the hormone positive patients are not getting that good a PAT-CR. Similarly, from the Trifina data, we again see the same results. We see TCHP is giving us the highest PAT-CR. We talk of PAT CRs of 80% when we are giving patients TCHP. But what we see, it's high in ER negative patients, the 80 to 84% patients. But in the ER negative patients or the triple positive patients, it's somewhere around 50%. So clearly, again, we see the difference in this biology of triple positives. The PAT-CR rate is much lower, even when we are going for a double EGFR, a double HER2 blocking antibody. But so why is this happening? This is what Sir just mentioned. There is crosstalk. And by crosstalk, we mean there is internal signal pathways in the HER2 PIK3 pathways. There is also the ER pathways in the HER2 positive patients. So when we block the HER2 pathway, the ER pathway gets dominated, and that leads to increased proliferation, leading to its relapses later in the setting. And this crosstalk is what is being uh, said to be a theory behind these relapses, which happen in ER positive patients in long term. But what we are also understanding is the subgroups, the molecular subgroups are much different. So when you look at the triple positive, so the HER2 positive, ER positive patients, what we see, 70% of these patients are luminal type and 30% patients are the HER2 enriched type. So what is the characteristics of these? They are ER dependent. They have low HER2 EGFR pathway activation. They have high rates of PIK3CA mutation. They have low proliferation and they have high TILs. Sorry, they have low TILs. But when you look at the HER2 positive ER negative subgroup, what we are seeing, 75% of these patients are HER2 enriched. A few of them can be luminal type, some of them are basal type, but 75% are HER2 enriched. And these characteristics, they are ER independent. They have high HER2 pathway activation. They have low rate of PIK3CA mutation. They have high proliferation, and they have high TILs. And it is because of this difference in the biology, what we are seeing between the triple positives and the ER negative patients. This is what is leading to the difference in prognosis and difference in survival. So how are we moving forward? Uh, this was just shown by Madam, the XTNet data with neratinib. But what we are seeing here, clearly, in the neratinib data, 1 year of neratinib after trastuzumab, there's a clear improvement in invasive disease-free survival, which is only in the hormone receptor positive patients. And there is not any benefit in the hormone receptor negative patients. What about affinity? When we talk of pertuzumab, trastuzumab, double monoclonal antibodies in the adjuvant setting, at 3 years, we saw there was no difference in the hormone receptor positive patients. There was only a 1.5% difference in the HER2 negative patients, in the hormone receptor negative patients. But now, in the latest analysis at 6 years, we see the difference in the survival curves happening. And now we see that there is about a 2.5% to 3% difference, and the difference is being seen both in the hormone receptor negative and the hormone receptor positive patients. And this is because hormone positive patients, they will have more relapses in the long run. And so this is expected that over time, these curves will separate more. We saw the Catherine data, and clearly TDM1 has become standard of care for residual disease. But this is clearly showing that there is no difference in the ER negative or the ER positive subgroups. So TDM1 is making an impact in both these subgroups of patients. So where is this leading us in clinical management? We saw all the algorithms previously. The only difference here is coming out to be that after neoadjuvant therapy, if we get PAT-CR and patients are ER positive, these are the patients whom you would offer after 1 year of trastuzumab or trastuzumab pertuzumab. You would think of offering 1 year of neratinib, and you would not do it to your hormone receptor negative patients. In TDM1, again, we do not know the role of neratinib. These patients were not included in the clinical trial, so this is an open question, whether we'd offer 1 year of neratinib to the hormone receptor positive patients. Moving on to the advanced breast cancer. First line, the trastuzumab pertuzumab taxane has become the standard of care after the Cleopatra data. In this data set, we saw there was no difference in patients who were ER negative and ER positive. Similarly, in the second line setting, TDM1, we have again seen no difference in these group of patients. In the third line setting, we have heard what we practice in India, lapatinib, capecitabine, trastuzumab, capecitabine. But of course, the new drugs are very exciting. The data sets we have just heard in the last few talks, trastuzumab deruxtecan, tucatinib data, and the neratinib data. One thing very interesting about the tucatinib data set, we've seen the benefit. The PFS benefit was seen in both the ER positive and the ER negative subgroups. But when we saw the OS benefit, it was higher in the ER negative subgroup and not that much in the ER positive subgroup. So this is something kind of telling us that the biology of early breast and metastatic breast is different, because we have seen the neratinib benefit is coming for the ER positive groups and not for the negative groups, but we are seeing a differential um, result with tucatinib. Now, is it difference because of the drug or because the difference in biology of metastatic versus early setting is what has to be seen. We saw this stride, very, very exciting results. Trastuzumab deruxtecan, patients who have progressed on multiple lines, including patients who have progressed on 7 lines of therapy, response rate 60%, duration of response 14 months. But what we see here, this was something good. Both the ER positive and the ER negative patients, both are responding equally well in this group of drugs. So what is moving forward? And this is where we are coming into separation of uh, algorithms for this group of patients. So here, this is using CDK4/6 inhibitors in the ER positive, HER2 positive subgroups or the triple positive subgroups. Now, we had seen the preclinical models. CDK4/6 inhibitors work best when you use it in patients who were ER positive, and also the second best results in the preclinical models were seen in the HER2 positive space. Now, this trial, the Monarch-HER trial, looked at triple positive patients who had progressed on 2 lines of therapy for advanced breast cancer with HER2 positive. It randomized them to 3 arms. Arm A was using abemaciclib with fulvestrant and trastuzumab. Arm B, abemaciclib, trastuzumab. And Arm C was what we would do in practice, trastuzumab with investigator choice chemo. And what we saw, clear improvement in response rates. You had chemo trastuzumab giving you 13.9% response and more than doubling, 32% response rates when you did the combination of a CDK4 inhibitor with hormonal therapy with trastuzumab. And even if you look at the progression-free survival, again, a very significant improvement. From 5.6 months, it went up to 8.3 months. Very clear statistical significance present in this arm. So clearly very exciting results, and everyone is impressed with this, and we are moving forward. If you see the, the number of trials of CDK4/6 inhibitors now going on in this space of triple positive disease, there are trials which are running in first line setting, metastatic setting, in the second line metastatic, in the third line metastatic, and they are using all the drugs which we have seen, palbociclib, ribociclib, abemaciclib, in combination with anti-HER2 therapy and hormonal therapy. So this is a space where we'll have to look at in future. We will have promising results. So I would like to conclude, triple positive breast cancer is a different entity. Please don't club it together with all the HER2 positives. It has different response rates, it has different prognosis, it has different survival than the ER negative HER2 positives. So this is very important because we kind of get obsessed with path CR, and that's in clinical practice. It becomes that we are chasing pathological CR. We are trying to tell our patients we'll be more aggressive and we'll get path CR, and if we get path CR, we know you'll do well. The bad side of it is you kind of put a frame in your patient's mind that if you didn't get path CR, you're not going to do well. And this is a message which we should get in triple positives. path CR is not so important. Even if you don't get path CR, these are patients who will do well in the long run. They may require long extended anti-HER2 therapy. There's no doubt about that, apart from the hormonal therapy, which we will be giving them. In future, it is desirable to design trials which differ in terms of HER2 positive and ER positive rather than clubbing them all together, because these patients' prognosis differ. And as I showed you, the CDK4/6 inhibitors, there are a lot of new trials going on which have shown an exciting promise in the triple positive breast cancer. I did not show the immunotherapy data sets in this, but there are some immunotherapy data sets also looking at the triple positives separately and looking at the ER negatives. But I don't think immunotherapy will be the way for the triple positives, but CDK4/6 in future will definitely have a role to play. Thank you very much. Thank you, everyone.